Notice the student in the back row. While the rest of the class moves in a blur of activity, they sit rigidly, gripping the edges of their desk, staring straight down. When parents and teachers see this kind of withdrawal, they usually reach for a familiar, comfortable word to describe it: shyness. That single label covers up a massive gap between a natural variation in human personality and a severe clinical condition. However, confusing the two carries distinct risks. We might overtreat a child's natural quiet temperament, or worse, we might look right past a student who is silently suffering from a highly treatable psychological disorder. Pinpointing the exact boundary between those two states is an urgent educational and medical necessity. Knowing the difference is how we stop students from falling through the cracks. Shyness, at its baseline, is a completely harmless temperament. A shy child might take longer to warm up to new people, but that trait does not inherently cause them functional harm. This diagram illustrates that exact divide. On the left, a soft, stable wave represents a natural, baseline temperament. On the right, a harsh, erratic spike marks the transition into social anxiety disorder. The first marker on that clinical side is internal motivation. A student with social anxiety disorder experiences a persistent, overwhelming fear of scrutiny, judgment, or embarrassment. Then come the external behaviors. This looks like a child actively avoiding birthday parties altogether, or experiencing intense physical distress, like stomach aches, right before a class presentation. To qualify as a medical disorder, these symptoms must persist for 6 months or longer, and they must significantly interfere with the student's ability to navigate school, family life, and friendships. Social anxiety disorder separates itself from an extreme personality trait because it is a quantifiable medical condition defined by long-term functional impairment. Identifying those clinical markers gets complicated quickly because we cannot judge student behavior in a vacuum. Every action a child takes is filtered through the lens of their cultural context. In certain families or communities, intense withdrawal and silence around adults is actively taught as a sign of respectful obedience. To an outside observer, that deep respect can perfectly mask intense anxiety. If a clinician evaluates a child without understanding the specific cultural background of their home, they are highly likely to misdiagnose the student. They might over-pathologize normal behavior or miss severe distress completely. Achieving an accurate reading requires clinicians who possess the specific cultural competence to read between the lines of what appears to be reserved behavior. An accurate diagnosis demands an equal pairing of objective clinical criteria and subjective, culturally informed interpretation. Standard school systems simply do not have the logistical bandwidth or the specialized personnel to identify and treat these complex cases at scale. MentalSpace School was built specifically for Georgia's K-12 system to solve this exact clinical bottleneck. The operational model connects schools with dedicated therapist teams, offering same-day teletherapy. These licensed professionals directly reflect the diverse cultural makeup of the specific communities they serve. Once connected, these clinicians deploy evidence-based treatments specifically designed for social anxiety, including cognitive behavioral therapy, gradual exposure, and group therapy sessions. Embedding culturally matched clinical professionals directly into a student's daily ecosystem eliminates the primary failure points that lead to misdiagnosis in the first place. Even with the right professionals in place, families still face hurdles regarding financial strain, complex insurance networks, and state regulatory compliance, like Georgia's upcoming HB 268 deadline. MentalSpace clears these logistical hurdles by providing full state compliance support, accepting a broad range of private insurance, and offering access for $0 out of pocket for Medicaid patients. This chart compares historical absence rates against treated students, revealing a surging column indicating an 89% attendance improvement. A secondary trend line overlays the chart, sharply descending to show a 92%